Turan joined my lab as a PhD student. Has it been a year, almost 2 years almost now, right?
Yeah, 2 years.
2 years, yeah. And so he started off working on this project and has carried out several experiments on ultrasound. So he's had to learn MATLAB coding and, kind of new things, and comes from a background in tissue engineering. So it's a
Yeah.
good fit.
Okay. So hi, my name is Akshay, and thank you for the introduction, Dr. Hoemann, and I am really thankful for the opportunity. Um, um, so just as my introduction, my work is based on early diagnosis of osteoarthritis and imaging it using the quantitative ultrasound. So um, yeah, this is my second year, almost like end of the second year, and we have done a couple of experiments that helped us developing and optimizing this imaging modality to investigate the cartilage bone interface. So before we start, I would like to give some background or introduction about the problem. So uh, first we talk about OA, osteoarthritis. So osteoarthritis commonly is the most common joint disorder among older population, and um, is considered as a degenerative joint disease where the cartilage tissue is eroded gradually over time, um, and conventional imaging modalities haven't been able to um, diagnose this early stages of arthritis, um, because it's usually considered as cartilage erosion. But even before the cartilage starts to erode, there are some subtle changes that are happening beneath the cartilage in the subchondral bone, like the micro cracks and tears. So to understand it completely, we have to look at the anatomy of the joint. So on the right hand side, you can see it's an image of a knee joint tissue, and you have uh, this cartilage, this blue layer capping the end of the long bones. This arterial cartilage is responsible for the smooth transition of forces across the joint. And so if you zoom it in, you can see the image on the right hand side. You can see that the cartilage in itself is composed, can be classified or categorized into different areas. Uh, there is something called articular surface or articular cartilage, which is an unmineralized region, no minerals there. And even the articular surface can be divided into different types of zones depending on the concentration of depending on the composition of the extracellular matrix and the structure of the chondrocytes. And uh, beneath this articular cartilage layer comes the calcified cartilage, which you can see here. This is fully composed of calcium, phosphorus, and like other minerals. So this tide mark, this undulating wavy layer you see before the calcified cartilage is an interface that separates the cartilage, the unmineralized region from the mineralized region. And um, it's and this is pretty much responsible for maintaining the thickness of the arterial cartilage in normal joints. And in osteoarthritis, this tide marked layer is known to is hypothesized to advance into the arterial cartilage, making the thickness of the arterial cartilage less, and hence like leading to more load on the surface of the cartilage and leading to more erosion over time. So as discussed, cartilage thinning is a hallmark of early OA, and conventional methods are not sensitive enough to detect it. And this tide mark, a structural feature, can be detected by the high frequency ultrasound, or other terms, scanning acoustic microscopy, which we use. So I will now describe briefly about the methodology. And first of all, let's talk about the goals. This is like the bigger picture of what we are trying to do is to develop and optimize SAM imaging methods to monitor changes at the cartilage bone interface or tide mark in bovine ex vivo models, because we have tried a couple of other animal models too, but we after some hidden trials, we found out like bovine seems to be a perfect model to study and develop our imaging methods. So how do we do it? Actually, so we have introduced some novel quantitative ultrasound parameters, which can help in detecting the tide mark remodeling. And some of these parameters are alpha, which is defined as the spatiotemporal increase in the backscatter and echogenicity from the tide mark. So it basically tells you about the intactness of the tide mark and its mineral level. Other parameter we were interested in this study, these kind of studies for like delta, which is actually the distance between the backscatter peaks coming from the tide mark and the cartilage surface, and it's a measure of the thickness of arterial cartilage. So by gauging the changes in these parameters, we can see the evidence of structural changes in the cartilage tissue. So yeah, and now the methodology. So we start off with this fresh shoulder on the very left top hand side, and we have this hollow needle, conjugate sheeted needle that we use to core our expands, and those expands are like 3 millimeter diameter thick, as you can see in the on this next figure on the next slide. So here you can see this white shiny surface on the top is like the arterial cartilage, and then there's an interface separating the cartilage from the bone. That's our tide mark, and you can see the subchondral bone underneath it. And then you place this thing into a 3D printed holder and to maintain the orientation of the expand while scanning. And we discovered it later in our pilot studies that maintaining the orientation is very important if you want to reproduce your measurements. So our expand is press fitted in this 3D printed holder the whole time while it's scanning, and even after scanning, like when we are treating with some other conditions, it's still kept in the 3D printed support to maintain its orientation. And yeah, and then you can see up the whole setup how this expand is scanned in PBS, and the transducer is immersed in the PBS, and yeah, it's scanned. So the transducer scans in a raster scan fashion in like a 3 into 3 millimeter square grid, and collect 61 scan lines in both X and point directions. And then we process our signals using a custom MATLAB script. And here you can see at the bottom in the right, in the oscilloscope, you can see these two clear signals, the one corresponding to the cartilage and the other one corresponding to the tide mark. Yeah, and here you can see the NFAS and side view images too that we reconstructed using the MATLAB code. So coming on to study one, the very first study we did was to verify the effect of EDTA on these parameters using a 15 megahertz transducer. So we code 6 other bovine explants, press fitted them to 3D supports. We scanned them at baseline, fixed them in 10% NBF, and then rescanned them, and they were decalcified for 4 days and were rescanned after each day of EDTA decalcification. We rinsed them PPS2 to get rid of the minerals before scanning, and the raw scan was acquired and the parameters were extracted using MATLAB. And for statistical analysis, we conducted a match pair test to see if there's any effect of EDTA. And we found out that there was actually a significant increase in the thickness of the cartilage just after 1 day of EDTA decalcification when you compare it to fixed expand. Actually, it was good enough to decalcify the whole calcified cartilage, and the signal was now coming from the subchondral bone. As you can see in the image on the left, is the image on the top is at the baseline, and the image is on the bottom is after 18 hours of EDTA decalcification, and you can see the distance has been increased between those two backscatter peaks, and the image at the tide mark is now much more fuzzier and much more weaker compared to the fresh. And you can also see the corresponding NFAS images these actually the segmented NFAS images. So on the top, you can see the scan NFAS images of cartilage and tide mark after 1 day of EGD at fresh. The first and second are fresh, and third and fourth are after first day. So you can see how this EDTA depletes the mineral in an outside-in fashion. And so now most of the mineral after first day is centered at between. And we were able to gauge these changes uh, in our parameters too. So if you can see the graph at the bottom, it shows you the results of the match pair testing we did. And you can see there's a statistical difference between the first day and the fixed for delta. And for alpha, it wasn't as strong as delta. You could see the difference, but only when you compare it at the 4 day. So we concluded from this that tide mark depletion can be detected by SAM scanning and measured using the delta parameter. So our study 2 was to develop methodology for longitudinal scanning. For this, we extracted 20 adult bovine shoulders along with some immature bovine shoulders too, which were never cultured. They were used for positive controls for ALP staining, which we'll come to later. So these expands were like before press fitted into 3D printed support, but this time they were press fitted permanently to maintain the orientation. And they were SAM scanned with the same 15 megahertz transducer at baseline and after 10 days. And the sections was also submitted for histology, for ALP, for detecting ALP activity, for checking the viability, and for visualizing the minerals in the cartilage tissue. So results of this study showed us that ALP stain was so ALP. So we conducted ALP staining, and we found out that some of that our shoulder was previously injured. So because of that, there might be a false positive result in terms of like ALP activity, because that injury might have induced ALP induction in some of the tissues where it's not supposed to be. So, but this is one of the explants where we which exhibited strong ALP activity, and you can see the NFAS images and how it was at baseline and how it was at after 10 days of treatment with a pro-mineralizing condition. And you can see the histology, the von Causa staining, the difrost staining, and the alkaline phosphatase staining. So all of these results led us to believe that longitudinal SEM scanning was possible in these bovine explants, and differences in delta were observed too after treating with those conditions. But the thing was, we had some challenges. We had like an already injured bovine shoulder, and there was some discrepancy between the thickness we calculated using our MATLAB code or delta and the actual histology thickness. There was a difference of 0.2 millimeters. And there was also like some patches on NFAS images, and we were expecting to see that, because when you think of a tide mark, you think of like a continuous surface layer when you see it from the top. So we concluded that probably we need a higher resolution transducer, and we also figured out like it's probably that we still need to optimize our method to scan our expanse. And one of the methods to do is to see if there's a difference or effect of focal plane while you are scanning. So in the next experiments, we try to address that. So the study 3 was aimed at developing a methodology for high precision SAM scans. And we took 4 adult and 4 immature bovine shoulders. We press fitted into 3D printed supports and scanned them with this time a 35 megahertz transducer. And all of the expands were scanned at baseline, and we scanned at 3 different focal depths. So these 3 different focal depths were cartilage surface, and between the cartilage surface and the tide mark peak, and at the tide mark peak. So the these different focal depths were set by adjusting the time of flight between the transducer and the region of interest. And this is one of the real explant, the immature bovine explant. These are the side view images and the NFAS images of it. So you can see how how in the NFAS images the focus is shifted from the cartilage surface to the tide mark. So and we measured the ultrasound parameters in all of these cases at baseline and the rescans, and what we found out that there was no significant change in the QA in the ultrasound parameters when focused across different focal depths. However, um, we saw that the explants that had like a poor that had like an irregular surface and like a severe tilt um, were associated with poor reproducibility of the ultrasound parameters. And we can see in the graph on the bottom side where you can see like how explants with tilted surfaces had their had like discrepancies in delta between baseline and follow-up scans, and we hope to address this. We actually developed this eligibility criteria to not to include explants with severe tilts for our analysis, so that can help us with the reproducibility of our experiments. And from this experiment, we also concluded that it is possible using SCAM uh, to visualize and see changes in tide mark remodeling for the expands which are not flat. So we conclude from this that our results suggest that high precision SEMS imaging can be used to detect changes in mineralization at the tide mark in bovine ex vivo models. And our future work will be focused on scanning these expands before and after culture in some more pro-mineralizing conditions. And we are also working on the automatic and accurate segmentation of tide mark in our MATLAB code. This is it. Please feel free to ask any questions if you have. Thank you so much.
Thank you very much for that wonderful presentation. Any questions you can put in the chat, or you can just ask. So in terms of sample preparation, would that involve then trimming and mounting so that you don't have a flat surface? Is that
so what we do for extracting expands with a flat surface is we core our expands, making sure that our Jamshidi needle is perpendicular to the surface of the cartilage, to the surface, like to the cause the natural curvature is a big problem. The natural curvature of the articular cartilage, and it makes harder to make our data reproducible. So we always aim to like at least like try to extract expands with flat surfaces. And we recently discovered like it's a job for two people to see, because it's hard for one person to see if the extracted expands are having flat surfaces or not. So yeah.
Okay. Any questions?
Sure. I have a couple of questions actually. Actually, wonderful work. It's very impressive how you managed to do this with tide mark scanning, with the SEM scanning to look at the tide mark. It's you could actually see the thickness of the cartilage with your scans, which is quite impressive for if you want to look at an earlier way. You could actually measure. I thought that was pretty cool. So when you're doing when you're looking, well, when you plan in your future experiments to look at see how calcification affects tide mark, so do you plan on looking at whether like specific OA factors are implicated in that, like inflammate like IL beta or some inflammatory factors in your culturing, and also do you plan on applying mechanics to that?
Exactly. So
for the treatment, yeah.
Yes, so we are trying to mimic early OA conditions, injury conditions. Cytokines, are there and other factors too. And also, once we find that these factors are able to change the tide mark mineral levels, we'll definitely go into the molecular mechanisms of it and try to deduce the mechanisms behind tide mark remodeling. Right. But yeah, first we need to see if these injury conditions, if the changes incurred by these conditions can be detected by our SAM modality of like we use a
Exactly.
what's that?
Yeah, no, exactly. Yeah, you have to
Yeah,
first
yeah,
determine.
yeah. So
Yeah, definitely. Also, I'm curious actually we started looking at osteophytes, and there's much less work on osteophyte in OA cartilage. So I was wondering if you had a chance to look at the time mark analysis in that type of cartilage.
yeah, so osteophytes are detectable by X-rays, but again, the time it happens is already too late, and most of the damage has already taken place. So we are investigating earlier stages of osteoarthritis, and one of the earlier stages is like the actual remodeling that takes place at the tide mark, which leads to the cartilage thinning, and so we are detecting on that part, and yeah, it's probably better to look at it than looking at later stages of osteoarthritis, I feel. So yeah.
Yeah, quite impressive. Thank you.
Yeah, thank you so much for that time. So uh, if nobody has any more questions, I'll probably leave for the lab. I have a lab teacher too. Okay.
Thank you very much, Akshay. That was wonderful.
Thank you so much. Thank you so much for your time.
Thank you.
Bye.
Yeah. So, I would like to introduce a wonderful friend of mine. Akshay, you can stop sharing so that Professor Hoemann can.
Yeah, sure.
Yeah, wonderful. So Dr. Karen Hoemann is a full professor of bioengineering at George Mason University at the SciTech campus in Manassas in Northern Virginia. So actually prior to this, she was a professor here in Montreal in the chemical engineering department at the Ecole Polytechnique, and where she spent about 15 years, Karen? Yeah. So
maybe, yeah, about, yeah.
Yeah. So working on the role of inflammation in articular cartilage repair. So she's highly regarded internationally, very brilliant. Her work on cartilage and bone tissue engineering and biomaterial-induced blood and innate immune responses. So really wonderful work. And as you see, she doesn't just do work to publish, and that's it. She is one of the few who has been able to have a product that's going through regulatory and it reaches the clinic. So absolutely brilliant work. So her research interest in thromboinflammation is being applied to developing new biomarkers of pro-thrombotic disease states, and also understanding how joint injury can destabilize the cartilage-bone interface. So our expertise draw from training in biochemistry, molecular cell biology, etc. So she did that at her PhD at MIT in 1992. And she has a long-standing interest in tissue engineering. She has direct experience in inventing and translating a biomaterial-based device for articular cartilage repair to the clinic. So this is, you probably have heard of BST car gel, and this was invented by Professor Hoemann. I remember those days. Also, we also worked with your product, Caroline. Really wonderful work. So she invented and developed this medical device for articular cartilage repair and that achieved regulatory approval for use in over 17 countries, and was eventually acquired by Smith and Nephew. So her lab is currently working on a new ex vivo model of thrombosis using a cultured blood clot system. Another area of research uses high frequency ultrasound imaging, what you heard with the Access brilliant work of ex vivo cultured osteochondral explants to identify signals that induce remodeling of the calcified cartilage layer. So Professor Hoemann currently has a Google Scholar citation index of 43 with more than 9,000 citations. So she's a member of a lot of societies, is an honorary member, for example, of the International Cartilage Repair Society. She's a fellow of International Orthopedic Research FIOR, which is a very prestigious recognition. She serves on the editorial boards of Cartilage Osteoarthritis and Cartilage Open, and also a co-founder of Kytogenx. So this is a biotech company specializing in devices for joint repair. So she's internationally recognized for expertise in orthopedics and biomaterials. So her talk is entitled Injury-Induced Remodeling and Regeneration of Hard and Soft Tissue Interfaces. Caroline, it's all yours.
I was fiddling with my slides. I wanted to make sure that you could hear me. Couldn't find the microphone.
Okay.
It's audible? Okay, well, thanks for coming today, even though I understand it's you have to. So I'm just going to give an outline of the presentation. So first I'm going to start with anatomy, and then I'm going to discuss a little bit of cartilage injury, actually cartilage injury induced by surgery, and then some cartilage repair models that my lab has looked into with the rabbit model. I'm going to go into a little bit of detail about other aspects of the ultrasound imaging in the rabbit, and then just a brief conclusion. So the osteochondral unit, it's considered an organ. Often people think of cartilage or bone, but now there's more thinking of an osteochondral unit. And it all starts with the bone in the fetal growth. Starts off as a piece of cartilage that becomes invaded by a vascular bone. And what this gives rise to later on in the growing long bones is an epiphysis and a metaphysis that are separated by a growth plate. So the surface of the outgrowing epiphysis is the future articular cartilage layer, and then we have the growth plate separating. And the spongiosum is this, they call it spongy bone. It's trabecular bone, but it's kind of thin and elastic because it's full of glycosaminoglycan and blood vessels. So actually, this growth plate will eventually turn into bone, and only the articular cartilage Anlage is spared from the full endochondral resorption. And just to illustrate this, we have a layer of collagen type 2 that's separated with the calcified cartilage, has collagen type 10, and the bone has collagen type 1. And at the end of skeletal maturity, the entire growth plate is converted into bone. So this tide mark is actually what is believed to save the articular cartilage from calcifying. And we can actually detect it histologically with a dye called hematoxylin, which is actually, during the staining process, is converted to hematin and then binds and forms a blue color through this aluminum complex. If we look at the cartilage bone interface, it's actually quite pretty in micro CT, and we can compare the micro CT image with the histological stain. And what you'll notice is that there's this process of endochondral ossification. So what is that? Endochondral ossification is where there are cells called chondroclasts, and they're actually resorbing the cartilage as the bone tissue is invading from underneath. And in the growth plate, this looks like this very lacy, heterogeneous surface that's in the metaphysis leading edge, whereas in the articular cartilage, the subchondral bone, you see this wavy appearance in the immature tissue, which actually was expecting to see in his bovine explants, which we do see by micro-CT. And then in the mature cartilage, you see this tide mark forming. It is wavy and smooth, and this leads to a more like a plate-like structure. So the tide mark actually looks different if you treat your tissues decalcified histology or decalcified histology or non-decalcified. And I remember the first time my histologist gave me these specimens with Goldner stain. I'm like, what on earth? Why are there chondrocytes in the mineral? And I realized, oh, because this green mineral stain in Goldner doesn't differentiate between calcified cartilage and calcified bone. So it looks strange because we're used to looking at decalcified tissue. And it's only really in the decalcified specimens that you can visualize the tide mark. And this is with, as you can see, the hematoxylin stain. So here's our osteochondral unit. This is the articular cartilage sitting on the calcified cartilage in the bone. And that leads us to our first question period. This is a class. So I'm wondering if anyone could answer. Go ahead and unmute yourself. True or false? At maturity, the articular cartilage is in direct contact with the subchondral bone plate. True or false? Who would like to answer? Unless everybody is out jogging or running errands with their video cam up. I'm going to wait till somebody answers.
You can write in the chat.
Yeah, if you're shy, write in the chat. I can't see it. I can't do a poll. Oh wait, there's someone in the chat. False. Yay. So someone said it's false. You are correct, it is false. Articular cartilage is in direct contact with the calcified cartilage layer. Okay, true or false? The final stage of endochondral ossification of an articular cartilage deep zone is the formation of a tide mark. I can't see this. Does anyone else want to try to answer? In the chat, I see true. All right. Whoops, I already gave away the last answer. The last answer is also true. It can be visualized in decalcified sections with the dihematoxylin. So you can see already there are really neat things you can do with histology and micro-CT. So as mentioned, cartilage lesions are usually treated if they can with the focal lesion. And one of the techniques that's often used is called bone marrow stimulation or microfracture. And if you let this go, the whole cartilage comes off. And this is a picture of a condyle from a total knee replacement. And there's no other way to alleviate pain except to replace it with a prosthesis if you don't treat it. The only problem is microfracture. Well, the technique was really pioneered by Stedman in the 1990s, and he kept talking about a superclot forms, and this blood clot somehow draws all these wonderful cells from the bone marrow to regenerate articular cartilage. But then people started taking biopsies and realized, well, not in everybody, and the older the patient gets, the less it looks like cartilage. So we want to develop an implant to maybe favor a more articular cartilage regeneration. And how do you begin developing a new therapy for microfracture? And one thing we noticed is that almost all cartilage repair procedures in use were tested in a rabbit preclinical model. And usually people start with a promise, but I'm going to start with the limitations. In fact, well, rabbits don't really reflect all clinical situations. Usually you create a defect in healthy tissues, whereas the patient tissue is lesional and it's very small. The cartilage is about 10 times thinner than human. It's kept in a cage, and it's inbred with a controlled diet, and there are no comorbidities, which are often seen in patients with OA. But we should test in a rabbit model. I believe it's actually quite useful because it gives us some in vivo data. Because if you get data in vitro, are you going to spend the money to do a large animal study? And many people would find that too risky. The fact of it, the repair being very rapid can save a lot of money because you only need to house the rabbits for 3 months maybe to get a result. And you can use autologous blood if you want to use a blood product, or PRP, platelet-rich plasma. And you need in vivo to see biologically relevant wound repair responses, including implant residency, clearance, angiogenesis, chemotaxis, inflammation, and signs of toxicity that might involve peripheral organs like the liver and the kidney and things like that. So the rabbit knee does not look like a human knee. And our models were using the trochlear groove as a model because if you put your implant in the condyle, often you risk getting it scraped off by the meniscus, and you can't control rabbit, mobility after the experiment. So often we use this more protected region in the trochlear groove for the defect model. So here's an example from the early seminal work by Mitchell, who actually was an MD and quite frustrated at the lack of techniques to repair defects. And actually Shepard was the nurse working with him, and he co-authored her on his paper. And here you're seeing the outgrowth of what I call like a hangnail. This is what happens in non-integrated spontaneous repair. We've reproduced this finding many times actually, but there are hallmarks of hyaline cartilage formation in this rabbit defect. And then in 1993, Fred Shapiro actually set the bar higher, and he showed that if you make a quite largish defect, 3 millimeters in diameter, that cartilage will actually regenerate in these large holes in, mainly immature rabbits. It's just that most of his data was descriptive, and he didn't say he saw a difference between young and old, but later on this was refuted by other work who showed that the young rabbits repair better with hyaline cartilage than older rabbits. But it's very heterogeneous. Repair is always very heterogeneous in terms of the quality of the tissue and the filling of the defect. So at this time, back in the early 2000s, we thought maybe a biomaterial could be used to enhance the repair of a marrow stimulation, and we turned to chitosan as a polysaccharide that was known to heal, skin wounds and burn patients. And this is a deacetylated version of chitin, which is chitin is an insoluble polysaccharide in crustacean shells, like shrimp shells, crab shells. And because you deacetylate, the positive charge allows it to be soluble in acidic conditions. And when you mix it with autologous whole blood, it actually forms microparticles, and it makes the clot more adhesive. And it's also biodegradable. And it stimulates wound repair because it attracts neutrophils. So we had a proof of concept in 2005. We published that these hybrid blood clots, which was later on became the BST Cargel product, if you treat a sheep microfracture defect with this implant, you can get a more hyaline and voluminous repair tissue. And it was after this we actually turned back to the rabbit to figure out the mechanisms of action. So I'm going to present today 3 rabbit models that we've been using to study cartilage repair. The first is the marrow stimulation, and also the imaging techniques we use to look at how the defect repaired. And then there's marrow stimulation with a pre-solidified implant. So we took the blood and solidified it with the chitosan outside the animal. And then, that reminds me, I have some videos I wanted to show. So, and I'm not sure it's going to work with the share screen. We'll see. I'm going to try and show some videos. How am I doing for time? I'm doing okay for time? Okay. And then marrow stimulation with a pre-solidified implant, and then intra-articular injection of chitosan oligomers. So this was the work of my student, Catherine Marchand, and she was developing a model for, well, micro drilling in the rabbit, testing the effect of different size drill holes. And just to add something interesting to this experiment, she used fluorescent chitosan when she made the implant so we could actually look at where it went. And this is a transverse view of the chitosan implant in the cartilage defect. So let me just see if I can, I might have to switch screens. Can anyone see the video?
No, we can't.
Okay, here. Can you see it now?
Yes, but it's not moving.
Okay, yeah, that's fine.
Okay, great.
So this is the rabbit microdrill defect, and Catherine and Gaoping are preparing the implant. She's shaking the chitosan into the autologous rabbit blood. And this is all done sterile. This is like a mock-up of what we did in the clinic, except here we put thrombin in the bed of the defect to accelerate solidification or, coagulation of the hybrid blood implant. So it solidifies in situ, and it's actually quite rapid, maybe actually just less than a minute. And the bleeding from the subchondral bone also stops. So let me see, I'll go back to my. So that was the implant that generated these images. And then Catherine went on to look at the effect of the surgical procedure on actually removal and replacement and regeneration of the subchondral bone. And what we found is that we thought we were debriding just the calcified cartilage in the defect, but what we realized is with scraping away of the tissue actually debrided the whole subchondral bone plate, and actually was removing a considerable amount of bone. So she wanted to go quantify how much bone was actually removed by this debridement and microdrilling. And what she found was that existing micro-CT models were able to measure this inadequately, because typically people used a square or rectangular cube, but the surface is curved. So she came up with two new models. One was called rectangle adapted surface, and then these CRASs, which were like just little kind of strips of VOI, of volume of interest, at different intervals from the surface. So at the bottom in panel K, you can see that the CRAS that covers the bone plate, it's pretty much all calcified, but this is the calcified cartilage layer, basically, with the subchondral bone plate, like in the Goldner stain. So here's an image of the 3D reconstruction of these different models, and you can see in the white speckles in A and even C how if you don't do the adapted surface, you're actually missing a lot of mineral tissue in your measurements. And what she found is that the bone volume over total volume in the top CRAS, shown by the red arrow, it's pretty much like 95% mineral tissue. And then as you get deeper into the trabecular bone, it's like spokes on a wheel. The bone gets less and less dense. So we concluded from this analysis that the most precise measures of bone loss and repair are with this rectangle with adapted surfaces, and she published this in Tissue Engineering C. So when we looked at the 6-month repair of these defects, actually the control defect showed a regeneration of the bones plate, similar to the treated defect. The thing that she noticed when she was going through her micro-CT images was that the bone holes, you could see residual bone holes in the controls that you did not see in the treated defects, because the chitosan was stimulating vascular bone repair. And this came out in this analysis she did of trabecular thickness distribution, where the treated defect showed a higher % deep bone repair than the controls. But the fact you had bone repair didn't reflect what was going on above it. And it was only with histology that we were able to show that, in fact, the control defects, like the original seminal study of Mitchell and Shepard, are these outgrowths that have very poor integration, whereas the chitosan implant, which stimulated tissue remodeling, bone remodeling, you had a more higher chance of having hyaline tissue, and it was significantly more integrated than the control cartilage repair. So we're reforming the osteochondral unit more reproducibly with the implant, and in terms of the integration. Are there any questions on that part? So I'm going to move on then, if not, to the pre-solidified. So the reason we moved on to this approach of treating the subchondral bone drill holes with the blood implant, the chitosan blood implant, is from having had some retired breeder animals. And we saw in these older animals the repair was insufficient. So we thought maybe we could boost the repair by putting the implant directly in the subchondral bone. So for this, again, we used a fluorescent chitosan incorporated into the autologous blood. And we played around with the molecular weight of the polymer. And here you can, and we also used clotting factors like tissue factor to cause the implant to solidify rapidly from these little microman tips you can see here. I have one more video. Let me see if I can find it. Oops, hold on a second. Let's see if I can do it. Oh, here we go. So here, the explant was solidified with tissue factor inside the tip. And then June, of course, this looks small. I mean, the implant looks small, but you have to realize these drill holes are really small. It's a rabbit. You have to, everything's scaled down. So we really optimized this system to know how much chitosan to put into one drill hole. We actually didn't know, but we put the original implant with a certain percentage chitosan microparticles into the drill hole. And we were testing the effect. Well, what if we use different molecular weight chitosan that clears slower or faster? And here is what it looks like. The defect bleeds more strongly when you drill a bigger hole. And so you have to coax in that implant where the blood is pushing it out. But eventually the implant is going to cause hemostasis. But the pressure from the blood underneath, we saw actually, you're going to see this in the histology of the fluorescence histology, it's actually kind of pushing it up. Kind of like, I can't think of a good metaphor, but like pushing an umbrella up, I guess. So the implant was there, and then the pressure from underneath was sort of, it was fun. I had some residents from Dalhousie that summer helping create these implants and do this experiment. So if you look at the right-hand side now, you can see the implant in the defect we just looked at. And then on day 1, this is what the implant looks like. And on day 21, this is what it looks like. And you might say, well, the repair tissue on the left looks better. We have white tissue. It looks like cartilage. And on the right, it's red. What is that? It's actually vascular tissue, but it's not a bad thing, because in slowing down the repair and causing blood vessels to come in, you get more woven bone and bringing stem cells, and you can actually get better cartilage repair tissue from that. So we did the micro CT, and we did this at McGill, and Alberto Carli was helping us with Janet Henderson. And I remember the first scans we got out of these experiment where the drill only, you could see the drill holes. And then with the implant, the holes were bigger. And we're like, what does it mean? What is going on? It's almost Halloween. So this is what we saw. And it wasn't until we got the histology, of course, you need histology to know what's going on. We saw that the chitosan implant, like I said, was pushed to the top. It all looks the same at day 1. And at day 21, we see that the large molecular weight, high molecular weight chitosan is still there, still drawing neutrophils. The 10 kilodalton chitosan is almost completely cleared. And wherever there were neutrophils, they drew in monocytes, and the monocytes turned into osteoclasts. So that caused bone resorption around the holes. We didn't realize this was going to happen. And then we have this here, that white tissue that you saw in the previous slide is actually fibrous tissue. So this is collagen type 1. So yes, there is a hasty connective tissue repair in the drill only, but it's actually this more fibrous tissue that's not what we want to see. We want to see, at this time, woven bone, and then later on, collagen type 2. So in fact, this is later on. This is at 2.5 months post-operative. And I'd like to draw your attention to panel F, where we see in the micro CT, look how the calcification is sort of blunted, and you're not seeing a full-blown endochondral ossification. What you're seeing is this callus formation. And this is what the calcification looks like when you have a callus forming, which is cartilage that's calcifying, and it's not actually growing much anymore. It's just turning into bone. So this is the appearance of the fibrocartilage, this hangnail, where it's poorly integrated in panel A. Look at the gap. And then this callus in E, you can see the hypertrophic chondrocytes mineralizing. And this is the treated defect, where you see this outburst of hyaline cartilage. And now look at panel F. You can see this full-blown endochondral ossification. It looks a little more like the growth plate. It looks a little more like recapitulation of development and a regenerative response instead of a fracture callus that's going to turn into bone. So all this work led us to understand the mechanisms of action in rabbit repair, that in early repair, the implant attracts neutrophils, angiogenesis. It really is a wound repair response, and you can get this bone remodeling, and this is all the work of Annick Chevrier. Delayed chondrogenesis, because if you delay chondrogenesis with the remodeling, then you can get a real regenerative response where you have articular cartilage growing up into the articular cavity. And this is the difference you can see in the treated and untreated and the best cases. So just to cartoon this idea, how does articular cartilage regenerate? It's when you have a vascular woven bone repair response and the stem cells are able to accumulate near the top of the defect. Osteoclasts can help this accumulation. And then you get the so-called chondroinduction at the apex of the defect. And these cells can then produce hyaline cartilage. All right, so let's move on to a little interaction. So here's another mini quiz. So pick the best choice. Can anyone remember the subchondral bone plate volume density in the rabbit? What is the volume density, bone volume density in the rabbit bone plate? Is it 45%, 65, 85, or 95? Let's see if anyone can venture in the chat. Someone is guessing. Did anybody guess A, B, C, or D? Someone has to type in an answer. B. It's a good guess, but actually the correct answer is D. The subchondral bone plate is actually, if you include the calcified cartilage layer, is almost all mineral, almost all bone. Yeah, it's very dense. So if you get rid of it, you've actually got a lot of bone to regenerate. So true or false? The bone plate regenerates 3 weeks after microdrilling in a rabbit cartilage repair model. Does the bone plate regenerate 3 weeks after 3 weeks of repair in a rabbit model? True or false? Oh, someone said true, but it's not long enough. So you can get some bone repair in the drill hole, but not the bone plate, not yet. So an implant that stimulates bone, I can't even see my text, bone remodeling can improve the integration of the regenerated osteochondral unit. Is that true or false? Because in fact, if you drill, you don't stimulate much remodeling. It's a very small remodeling response. So in fact, it is true, but it's not the only condition that causes cartilage to regenerate. So here for the end of my presentation, I'm going to go over some different imaging, which has only been happening since I came to Mason through a collaboration with Parag Chitnis. He's a professor in the imaging pillar of our department. And that's on the use of ultrasound is another imaging technique to study cartilage regeneration. So I'm just going to briefly go over an experiment that we started right before I moved here, and that was to look at whether or not we could use intra-articular injections to guide cartilage repair. And the idea was that the chitosan we saw in tissues attracted these so-called helper macrophages, the M2 macrophages, and we thought, well, maybe we could just get the synovium to have M2 macrophages, and these macrophages will release wound healing factors that improve the cartilage repair. So for this model, we actually we set the bar higher. We made a cartilage defect to make a chronic defect, which is more mimicking the clinical situation. And after 28 days, we considered this to be a chronic defect, and then went back into the knee and did marrow stimulation. We did 4 drill holes. And then a week later, we started 3 weekly injections of chitosan oligos or saline or Synvisc, which is hyaluronic acid. It's actually used clinically for, well, in osteoarthritis is a so-called viscosupplementation. And so after 3 weeks of these IA injections, after the last day, we waited 1 more day. We did a necropsy, we fixed the tissue. They sent them down here to Mason. We did ultrasound scanning, and then I shipped them back to Polytechnique for histology. And these are the conditions we studied. We looked at different types of chitosans, and then our controls were Synvisc or saline. So this is the appearance of some of the defects at necropsy. And there was an intact trochlea, just for an example, the chronic cartilage defect. The microdrill defect we made ex vivo. We didn't do that in vivo. Of course, the holes would be filled with blood clot if we did. This is something we just drilled outside the body. And then you see the repaired defect. And, you know, if you're a surgeon, we usually did this macroscopic scoring where we asked the surgeon, well, what percent fill do you see in that defect? So maybe 50% on the left, maybe 95% on the right, but you know, it all really is kind of instinct. We don't know. We have to measure that somehow. So about this time, Parag Chitnis showed me a scan he did of a penny. I'm like, oh my gosh, a penny, you're kidding. You could probably do that in the articular cartilage repair defect and see all the repair tissue surface. So I thought, let's do this. Let's look at cartilage repair tissue with this technique, this scanning acoustic microscopy. And just to show like how, you know, how precise is this? I stacked 3 cover slips on top of each other, a microscope cover slips, and scanned them. And here you can see the steps are quite clear, 100 micron steps, yellow, blue, and green. So you can discriminate 100 microns. We wanted to get a little bit better than that, but 35 megahertz transducer can discriminate pretty fine features. And as Akshay explained, the way we do this is we submerge the osteochondral sample in a water bath. The transducer must be submerged in the aqueous solution. The sound travels through aqueous solution. And it's because sound has a constant, there's a constant speed of sound, just like a constant speed of light. Sound has a constant speed, and the time of flight will depend on where it's reflecting from. So if you put a mirror underneath the scanner, the time of flight is simply the distance between the transducer and the mirror. Excuse me. If you put a piece of cartilage and bone there are 2 times of flight that are major, one at the cartilage surface and one at the bone. So here you can see the trace on the oscilloscope where the first backscatter peak, and we can measure the distance between the transducer and the cartilage by the time of flight in this small distance, and then the second peak. There's the setup, and it's a homemade setup, and there are 2 motorized stages that move the transducer, and we do what's called a raster scan. So what we do is we collect we collect focal ultrasound scan data every 100 microns in a kind of back and forth pattern. In the motorized stage, you can program to go slower or faster between these spaces. And you know, the scan can take 4 hours, it can take 20 minutes. So what we did was we optimized in the beginning the length, the scanning parameters, so that we weren't sitting there all day long scanning one sample. And you could see some features change a little bit if you go from an 80-minute scan to a 20-minute scan, but I think we wound up going with the 40-minute scan. So what we found was you can discriminate between cartilage and bone with this technique, and there are some spots you can see where there was no cartilage repair and it was overlapping with the micro-CT scan, but there is like a gap between the cartilage surface and the micro-CT surface when we did the co-registration. And then I came up with a method to measure the % defect fill for the whole defect, not just one slice of tissue, but the whole defect, because we did do histology. We have 1 slice histology through the defect in the sagittal plane. And I reasoned that if we took the average thickness of the tissue between 2 areas, one directly below, one directly above, that this average thickness would be the same as the average defect fill. So in histology, this just to give you an example how it's usually done, you take 1 histology section through the middle of the defect or through the holes, and then you kind of extrapolate from the sides and you make a virtual, like how much should it be filling if it were the regular tissue, and then you can come up with this kind of quantitative schema where here we found that the saline, actually the vehicle treated knees had the best tissue fill over the drill holes. Whereas the chitosan that drew too many neutrophils into the joint had the least repair tissue filling the defect, but there was some repair tissue. Not much more than 1 week drilling, which at this point is still a kind of fibrin clot. So this is the traditional way of measuring fill, but this is only 1 section through the whole defect. So this is the result we got when we did the 3D ultrasound. And now what you can see is we have a comparison of the intact knee, which the average thickness of cartilage is around 200 microns. This is 0.2 millimeters. And what we can see is that at the initial defect, there are holes. We remove tissue. So the defect thickness is actually less than 0 because of the microdrill holes and the debridement. And then after 1 week, we have some fibrin clot in the defect, and the chitosan that drew neutrophils into the joint is fighting against some kind of catabolic environment, whereas the saline and one of the chitosan formulations in Synvisc are allowing tissue to grow out. So I looked, since these are 3D images, I can tilt them and look at them different ways. And this was one interesting thing. I looked at from top down, and then I tilted and looked up from the underside. And what you can see is that there are actually biomechanical measures of this technique that you don't get with micro-CT. And that's the sound penetration into the granulation tissue. And what this analysis revealed was that in the initial defects, the sound penetration into this bone holes, you can see all 4 drill holes. And some of the formulations, like the inflammatory one that drew neutrophils, the holes are still forming a mechanically weak granulation tissue compared to the other chitosan formulations and saline. If you look this more closely, you can see the saline granulation tissues have a higher mechanical integrity than the knees that were injected with this chitosan formulation. So to conclude, there are different imaging modalities of articular cartilage repair in rabbit models. Marrow stimulation can only initiate regeneration, and we can use implants to alter the way the tissue regenerates. And at 3 weeks, you can use micro-CT to look at the mineral density and the repair bone structure. If it's remodeling or absorbed, histology can tell you more about the matrix composition. You really do need histology to look at the cells and what the tissues are in the defect. And then the ultrasound that we did showed you can get entire defect fill and maybe a measure of granulation tissue mechanical density. And at the 6-month repair, the micro-CT can show you the bone repair, but it does not predict the cartilage repair quality, and the histology is still the gold standard, but cannot give you the percent fill for the whole defect. So I'd just like to thank everyone who helped me work on this project. And I would like to take any questions if there are any.
Thank you very much, Carolyn, for that wonderful, excellent presentation. Anybody has some questions?
Just hang on, I got to turn my volume up.
Okay.
Okay.
So, Carolyn, you were talking about those sum was really brilliant, really nice. So, what sort of material properties were you looking at? Can you deduce from when you're doing sum?
Yeah, the biomaterial properties. Well, we have not done ultrasound scanning of the implants.
Okay.
But yeah, that could be interesting. But one thing I realized is if we had done ultrasound scanning of the initial defect in vivo, we would have not seen any difference between day 1 and week 1. Because
Okay.
any tissue at all, if it's a blood clot or granulation tissue, it's going to reflect the sound.
Right.
So yeah.
Yeah. So when I saw the experiments where you're showing different percentage deacetylations of your chitosan, and what's your feel in terms of which is the optima, which one do you gravitate towards? I saw you are using at some point 80%, 98%.
Yeah, so these chitosans, you can tune them to be really acting on the innate immune system to attract neutrophils or attract more monocytes. And the ones that were 80% deacetylated that had N-acetylglucosamine are really attracting too many neutrophils. And so one thing I would say that this study was useful for ruling out using those types of chitosan intra-articular injection. It was as though we were creating a model of rheumatoid arthritis. If you draw neutrophils chronically for 3 weeks into the joint, you are going to cause joint degeneration.
Okay.
And so for the other ones, we stopped the study too soon to actually say if Synvisc or the 98% deacetylated, the highly deacetylated chitosans could be potentially beneficial. So both of them slowed down the repair response.
Right.
And the one thing we notice is that we still got the hangnail or unintegrated repair in the control drill holes. So it's possible that we could get a better integrated tissue if we use the intra-articular injections. It could potentially improve, but it would also delay repair.
Right. Right. Any other questions? Mike? So you can put in the chat if you like to ask. Yeah.
Well, how about the audience? Is there anyone in the audience who is interested in doing orthopedic surgery for their, well, if you're in medical school, if you're interested in orthopedics? How about trauma surgery? Actually, I did a observership in trauma ICU or the orthopedics trauma, and
Okay.
yeah, they do some joint things, but mostly fixed bones,
Right.
broken bones.
Hi, Caroline. Yeah, thank you very much for the presentation. I'm quite impressed, yeah, with the work and what you've accomplished so far. The Kaizen treatment is quite incredible. We had a chance to work with Kaizen, but yeah, I'm impressed that you're able to we never really looked at the deacetylation factor so much, but it's certainly something to consider when we're talking about inflammation and repair. So I guess my question was related more to the repair in weight-bearing joints and the timing. So is there a gold time, like some sweet spot in terms of time, if you're going to deal with the repair of a cartilage defect in a weight-bearing area?
Yeah, we've seen that in the sheep model, and actually in some patients, that there is some kind of intrinsic ability to regenerate cartilage that's lost over time. And there was one, and so in the sheep defects, you can get an outgrowth of cartilage tissue in weight-bearing condyles, and all of our models in sheep were in weight-bearing condyle defects. There's just a funny anecdote about the very early clinical use of BSD Cargel, where some patients were treated with that who had osteoarthritis. And at one point, I was working on in the biotech company on the implant, and they said, oh, they had to do a total knee replacement on one of the patients that got Cargel, and they're going to give us the tissue. And it turns out it's a little more than a story about failed repair. What happened is the surgeon was very skeptical. He said, oh yeah, it's this new implant, and oh, now I got to do the total knee. And then he opened up the knee joint and he saw this pearly white tissue growing out from the treated area, surrounded by this horrible, degenerated, mineralized tissue. And he said, oh my gosh, go get the camera. Go get this. I got to give this to BioSyntech. We got to give this to them so they can study this tissue. It's just amazing. And when they called me out to help do the histology processing of that tissue, all I could say was we decalcified the piece of condyle, and then I touched it with the forceps, and I'm thinking, oh my goodness, this cartilage outside the repair area, it's like calcified cartilage. It's grainy.
Oh, wow.
And some people with osteoarthritis. So in fact, that patient was not an indication for cartilage repair. And that's one of the things in cartilage repair where it's up really the surgeon's call, am I going to go with this cartilage repair therapy, or really they're too far gone and they need a total knee replacement. So this really is kind of a decision-making algorithm that it's beyond the product development.
Mm-hmm. That's pretty cool.
So the previous speaker last week, Fabrizio Ambrosio, I don't know if you know her from Harvard, and she was talking about these extracellular vesicles that are released, and so she was using like blood from young and old, and she sees differences once you remove these vesicles or you add the vesicles, which was really fascinating. Since you are working with blood clots, um, do you have any comment on the blood, or is there you are using, because at some point you showed that you were used with older animals and then younger animals and try to see, do you see any differences, or do you think there's any role of such kind of vesicles involved in either accelerating repair or retarding repair?
Were her EVs from like mesenchymal stem cells or something? I'm not familiar with her work.
Yeah, so her EVs were coming from, I think she just would get them from the blood. I know that a lot of people get EVs from.
Oh, she's using blood-derived EVs.
Blood derived, yeah.
From the animal or human or?
From the animals.
Okay. Okay. Yeah, I've studied microparticles are larger extracellular vesicles, and you can collect them by spinning in a regular microfuge, a high-speed microfuge in your lab. You don't need an ultracentrifuge to purify those. And I've studied those in terms of their procoagulant activities.
Right.
So they are procoagulant for the contact pathway, like factor 12, the contact pathway. And I do know that in some disease states, they start acquiring tissue factor. And a lot of these vesicles, they just come in the blood. They can come from any tissue, actually.
Right.
They don't just come. And when the blood clots, a lot of the EVs now are going to be like platelet-derived extracellular vesicles.
Right.
It's just the one thing I have to say about that particular biomaterial is that I would not expect the half-life to be very long.
Right.
And in large animal models, and if you get an effect in small animal models, I would challenge the researchers to show that they can get an effect in a large animal model, because what we saw was that the responses we see at 3 weeks in rabbit take 3 months in the sheep.
Right.
And if you have a clearance rate of probably 1 day, because they did show that Synvisc, the hyaluronic acid, clears after probably 1 day.
Right.
But you can get lasting effects of Synvisc because the synoviocytes apparently are responding to the presence of that biomaterial. So I would say that if the EVs are having an effect, and if you're hoping it would last longer than 1 day, it would have to be because they are influencing the cellular reactions of other tissues that can be lasting for some time. And they would have to last a while to influence repair in a larger, like in a human tissues.
Right.
Because you can have, like, when you do microfracture in human patients, they can have some knee pain a good 3-6 months after the procedure. Usually 3 months after the procedure, they're still experiencing knee pain from the microfracture itself. It's healing. And then 6 months later, they're actually doing really well if they've had that, then when they had that implant. And so if you're thinking, well, if I want to inject something that clears after a day, and the patients are still undergoing this wound repair with all of these things going on in their knee, including like fusions and all that fluid in their knee, and then this is what I'm going to inject, it's going to change something, it's blood-derived EVs, you have to say, well, there's already blood in their joint, a little bit of blood, and it's going to have to influence over that. And the reason why the chitosan has a chance is because those are microparticles, and they're in the clot. So they're staying in situ at the wound site, which is different from injecting something that goes all over the joint cavity.
Right.
So a lot of it also is like, are you targeting a specific tissue or just treating the whole joint? And then can you actually show like a mechanism of action, like why is it working? that would be challenging, I think.
Yeah. Nice.
I didn't mean to disparage or anything like that. I think, the work is very promising. A lot of people are working on EVs right now as promising ways of influencing tissues. And you can get EVs out of blood, so I would say she should keep working on that because it's interesting.
Yeah, we used to, more than 30 years ago, we used to get these matrix vesicles from growth plate chromosomes. And if you give them like radioactive calcium, they would uptake calcium, and you could follow over time as you get an uptake of calcium. And we were just getting them through centrifugation, and you get this. We used to call them matrix vesicles at the time, before all this.
I remember that work. I remember it's fascinating.
Yes, yeah, but in those days, it was tough to get funding from NIH because the matrix vesicle field, we were like 30 people at the conference, and the rest of the people were like, wow, they didn't believe in them very much. Now they're all over the place.
Yeah, you were too early in the insights. Well, and the other thing I would say then about those EVs is that you have to think about manufacturing, and chitosan is a naturally derived product.
Right.
So in fact, it's way cheaper to manufacture than a cell-derived products are expensive. And there's a cold chain or storage problems and it's half-life problems. And so, when you're thinking long-term in terms of translation and uptake, everything you make that's biodegradable has a limited shelf life, just like milk and eggs,
Yeah.
And what you can find is if the clinicians aren't running to get your product and use it, you could manufacture a huge batch of extracellular vesicles and it'll sit out and then you throw it out.
Right.
And so it's passed through the second valley of death and it's just burning money. It's just in the burn rate.
Right.
So all of these things you have to be concerned about is it doesn't have to be scaled. If it's autologous, you have to figure out a way of doing it, but how much time does it add to the procedure? Is it reproducible? How do I do quality control? So all of these things, these are obstacles in getting that into a real therapy, that it's really challenging.
Yeah.
Especially the cost, how much are you going to charge? Is it reimbursed? Nobody's thinking when they start these projects, how am I going to get it reimbursed?
Right.
Insurance. It's like, it's at the end when you say, oh, we want to license it. But, well, is it going to be reimbursed? How? What?
Right.
I have to worry about that. I do research.
Yeah.
I don't do it. I'm not an Anthem Blue Cross. Yeah, I don't know.
That's an amazing point. Actually, it's true. Especially the timing, how long is going to last inside the patient, but to acquire it, especially the EVs, and when they do, it's actually finding EVs from younger donors to inject into older, right? So that is another hurdle there.
Yes.
Well, that's transplantation, and there are other issues with that too. What I found out recently was in blood transfusions, they no longer transfuse women's blood. Because after pregnancy, you can have antibodies, MHC antibodies, and it's too risky. So post-parturition.
Right, yeah.
So they actually only use male donor blood. So are you going to only use EVs from male donors?
Yeah.
Are they going to be contaminated with antibodies? And there's all that just increases the risk tremendously then. And the sterility, or they have a blood-borne disease, all those things around the 80s circulating around HIV and hepatitis. Like, how are you going to screen that? And are you going to pool it? And then especially with COVID too. And who knows if long haul COVID isn't because it sticks around and quietly. And how are you going to screen for, how many things can you screen for in that, in the batch? because that was another unexpected challenge in the manufacturing was when you make a batch of the BST car gel, they took half of that batch for quality control. Half of it.
Half of it.
Half of it.
Hmm.
They had to do, and that was for a limited certificate of analysis. So we're talking about they had to do viscosity. They didn't do molecular weight on the COA, but they had to do viscosity, sterility, and that means that out of a batch of 100, 200 vials, they select randomly 100 probably.
Hmm.
Yeah, it adds to the manufacturing cost. So what are you going to do for the EVs? You have to make twice as many as you need.
Right.
And what quality control test are you going to do on that? It's going to satisfy the authorizing bodies, Health Canada or the FDA, that it's not posing a risk for the patient,
Right.
especially for a non-fatal, it's not cancer, it's arthritis or whatever. So it's not like they're going to die if you don't do this. So whatever, you have to weigh it against the risk against the benefit more.
Right. That's wonderful. So thank you very much, Caroline. I like all these cool methodologies that you use.
I hope it's been useful for the participants in the session.
Yeah, thank you very much, and thank you,
Yeah,
everyone.
any feedback would be welcome
Yeah.
on the presentation.
Yeah. A wonderful student. Thank you, Ake.
Yeah, I think he's teaching. He said he had to go to the lab. He's going to. I'm teaching a lab class right now. He's taken up. He's the GTA for my lab class. That's what he meant by going back to the lab.
Okay.
We have we're doing a dot blot assay today. The students are doing a dot blot of a biotin avidin system.
Okay.
Oh, nice.
So he had to start. I have to go up and see what my students are doing, actually.
Thank you very much, Caroline, and have a wonderful.
Yeah, have a great day.
Thanks again. Thanks for accepting, and thanks for giving me your time.
Okay, great. Bye.
Bye.
Bye.